Endotracheal suctioning involves the removal of sections by means of passing a catheter into the endotracheal tube. Before suctioning, determine if your institution requires an order. If so, obtain one. If a standard protocol for endotracheal suctioning is in place for intubated clients, be sure to adhere to your institution's policy when implementing the procedure. Clients with an endotracheal tube require suctioning when there are visible secretions in the airway or if the client is coughing or breathing against the ventilator. Other indications for the need to suction can include a transient increase in peak airway pressure, a decrease in tidal volume, or even a decrease in oxygenation, as noted by decreased SaO2. The nurse would suspect airway obstruction due to the presence of secretions or a mucus plug if the breath sounds are diminished or chest rises less than expected. When suctioning is required for a client with an endotracheal tube on the ventilator, the general practice is to use an inline suction catheter. These are especially helpful for clients who require positive end expiratory pressure, usually referred to as PEEP. Opening the system would create a loss in positive pressure on the alveoli. Suctioning is a sterile procedure. Although the inline suction catheter is a closed system, hands should be cleansed prior to any client procedures. In this case, use of an alcohol-based rub is as satisfactory as using soap and water. Check the setting for the suction device used for this suctioning. It should be set at -80 to -120 millimeters mercury. Prior to suctioning any client, conduct a baseline assessment for comparison during and after the procedure. Review the client's previous arterial blood gases and oxygen saturation values when available. Evaluate the client's ability to cough and voluntarily deep breathe. This will help the secretions to clear from the lungs as well as increase the tidal volume during the suctioning process. Be sure to explain the procedure to the client prior to starting, informing him or her that suctioning often will cause people to cough or gag or even feel as if they are short of breath during the procedure. Telling the client why suctioning is needed might help to increase cooperation or tolerance. Throughout the procedure, offer frequent reassurance in order to reduce anxiety and minimize oxygen demand. Position the client in semi-Fowler's position unless contraindicated. This will promote better air entry into the lungs as well as allow the client to cough more effectively. The client should receive a brief period of high concentration of oxygen. This is called pre-oxygenation. It can be accomplished with a manual resuscitation bag or with a setting on the ventilator. Using the ventilator setting, pre-oxygenate according to agency policy and patient needs. Modifications in this step are made for clients on PEEP. If using the manual resuscitation bag connected to an oxygen source, squeeze the bag every 5 seconds for 30 seconds to hyperinflate the alveoli and increase their oxygen stores temporarily. Put on personal protective equipment as appropriate. It should be no more than 1/2 of the diameter of the tube. Quickly but gently insert the inline catheter into the artificial airway without application of suction. Withdraw the catheter 1 to 2 centimeters to avoid suctioning tissue and apply intermittent suction while removing the catheter. This aspiration should not exceed 10 seconds but should be slow enough to allow for mucus to be grabbed by suction tip. Before suctioning again, pre-oxygenate the client as before prior to another suction pass. To promote clearing of the secretions, ask the client to cough in between suctioning passes, if possible. If the mucus seems too thick to move through the suction tubing, it is not recommended that saline or any other liquid be instilled in the endotracheal tube. In fact, saline and sputum act much like water and oil. If secretions are thickened, then increase the overall hydration for the client and use of mucolytic prior to suctioning. Once the suctioning process has been completed, and during suctioning as well, monitor the client's heart rate and rhythm, auscultate the lungs again, and follow the oxygen saturation level. Note the quality of the secretions, color, thickness, odor, and amount, and document in the client's record. The inline suction catheter is often packaged as a self-contained unit. It should be replaced if it becomes clogged or per the facility's replacement policy, often after 24 to 48 hours. The suction tubing connected to the canister is often changed when the canister is changed. This is when the canister is full or the secretions are thick or discolored. After any client care procedures, the hands need to be cleansed. When you are finished and the client is settled, document the change in the client's breath sounds and the client's response to the suctioning procedure. In the event the client does not have an inline suction catheter, then follow these steps. Assemble the sterile suction catheter, sterile gloves, and sterile basin filled with sterile water on the bedside table. Pre-oxygenate the client as described earlier using the manual resuscitation bag or ventilator setting. Be sure the connection of the ventilator tubing to the endotracheal tube is loose enough to be released with one hand. Open and put on the sterile gloves. Grasping the paper wrapper and the suction catheter, connect the suction catheter to the suction tubing. Remove the paper wrapper from the suction tubing, maintaining its sterility. Disconnect the endotracheal tube from the ventilator. Quickly but gently insert suction catheter as far as possible into artificial airway without application of suction. Withdraw the catheter 1 to 2 centimeters to avoid suctioning tissue and apply intermittent suction while rotating and removing the catheter. This aspiration should not exceed 10 to 15 seconds, but should be slow enough to allow for mucus to be grabbed by the suction tip. If repeat suctioning is required, then repeat the pre-oxygenate steps as before. A second person will be required to do this manually so as not to break sterility. Rinse the catheter by dipping into sterile water between suction passes. When finished with the endotracheal suction, the rinsed catheter can then be used to suction the client's mouth before and after oral hygiene. Having an endotracheal tube can be uncomfortable. Oral hygiene is very important to the client's comfort. Wearing non-sterile gloves and using a soft or foam toothbrush and mild toothpaste is recommended. Use half-strength hydrogen peroxide and mouthwash mixed with water per your facility's protocol. Oral suctioning with an oral suction tip is used to remove dripped liquids from the oral cleaning procedure. As described earlier, monitor the client's response to the suctioning. Cleanse hands and document the response in the client's record. Suctioning is a necessary support procedure for clients who cannot clear their own airways. It is done with caution and comfort in mind. While it can appear to be very uncomfortable for the client, the results are better oxygenation and therefore increased client comfort. A tracheostomy is the surgical opening into the trachea, allowing the placement of an indwelling tube to maintain patency of an airway. A tracheostomy tube might be inserted for emergency situations, such as airway obstruction due to laryngeal edema, foreign body dislodgement, or tumor. Or it could be used as an alternative to long-term artificial airway use, for instance, an endotracheal tube. A cuff tracheostomy tube stabilizes the airway for an unconscious or paralyzed client who does not have the ability to cough, mobilize secretions, or maintain an open airway. Additionally, the tracheostomy offers the client a route for clearing secretions as well as prevents the aspiration of food into the lungs. A client would have one of 3 basic types of tracheostomy: cuffed, uncuffed, or fenestrated. The fenestrated type allows limited speech as air passes through the upper airway when the cuff is deflated and external opening is capped. Whichever type of tube is intact, the goal of tracheostomy care is to prevent infection and skin breakdown at the site and maintain a clean, dry, stable airway. A client with a tracheostomy has secretions that collect through the tracheostomy tube and require suctioning. These secretions can also cough around the tube such that the skin and tube require special care. Because the tracheostomy tube is holding open the airway, special care must be taken that the tube is not dislodged during the cleaning process. As before any procedure, wash your hands and wear gloves. The soiled dressing is removed by gently loosening it from around the neck plate. Inspect it for color and odor of drainage. Cleanse around the neck plate with cotton applicators that have been moistened with sterile saline, hydrogen peroxide, or other approved antiseptic solution. Repeat this procedure by rinsing the skin around the neck plate. Avoid dripping liquids into the tracheostomy opening to prevent aspiration, while providing a thorough cleansing of the neck plate. Wipe only once with each pad and discard it in order to prevent contamination of a clean area with a soiled pad. Repeat the same cleansing procedure under the neck plate, on the skin of the client. Be sure to use cotton applicators to dry the skin under the neck plate to prevent skin irritation or breakdown. If the tracheostomy tube has an inner cannula, then the sterile cleaning of it can begin now. Remove the inner cannula from the outer cannula and place it in solution of hydrogen peroxide and sterile saline to soak. Nurses differ on whether they do this before or after the cleaning of the neck plate. The soak should not take but a few seconds, so either timing is good for the client. Take off the non-sterile gloves and wash hands, then place on sterile gloves so that the inner cannula can be cleaned. Using the tiny wire brush provided, scrub the inside and outside of the soaked inner cannula to remove all secretions. Rinse it in the sterile saline basin and dry with sterile gauze. Then gently slide the inner cannula back into the outer cannula and lock in place. You will not have cleaned the outer cannula at all. It is preferred that a second person be available to assist with changing the ties on the tracheostomy, only because there should be no opportunity for it to be dislodged. An obturator is kept at the head of the bed to place in the tracheostomy opening in the event the outer cannula of the tracheostomy tube comes out. As this is an emergency situation, it should be avoided by having the second person with you for the brief time it takes to change the ties. Cut 2 pieces of twill from the tracheostomy cleaning kit, about 12 to 14 inches long. Make a fold about 1 inch below the end of each piece of the tape and cut a 1/2 inch slit lengthwise in the center of the fold. Have the second person gently hold the tracheostomy tube in place with gloved fingers on both sides of the neck plate and providing reassurance and distraction to the client. Untie the old tracheostomy ties. If they are difficult, be careful if cutting them, as you do not want to cut through the cuff inflation tubing. Use tweezers to pull at them until they come loose from the neck plate. Insert the split end of the tracheostomy tape through the opening on one side of the tracheostomy tube neck plate. Pull the distal end of the tracheostomy tie through the cut end and pull tightly. Do this on the other side as well, while the second person continues to stabilize the neck plate. Then tie the tracheostomy tapes with a double knot at the side of the neck to avoid any pressure source at the back of the neck. These tapes need to be snug enough to hold the tracheostomy tube in place while allowing one finger beneath the tape for neck movement. The second person can leave now and wash hands. There is a split gauze in the cleaning kit that will slide under the neck plate of the tube to provide a cushion for the skin and absorb secretions. Discard all used materials and wash your hands. As with all procedures, document the client's response to the treatment and that the treatment was completed. This procedure becomes more comfortable for the client the longer the tracheostomy tube is in place. As long as the client is made to feel secure and secretions are frequently removed, the tracheostomy cleaning procedure should feel safe for the client. Ideally, every client's environment should be restraint-free, and it is every nurse's goal to make it as restraint-free as possible.